Good afternoon, everybody. Thank you for joining us for this afternoon. Today we'll be having a session on biochemical assessment in medical nutrition therapy. I'm Dr. Derek. I'll be the moderator for the moment. And with us is Madam Sarah Gikonyo. Sarah Gikonyo is a nutritionist at Kenya National Hospital with a bias in nephrology and the critical care nutrition. So I request that you listen in till the end of the forum, and then, but also at the same time, you can engage on the Q&A section in the chat box, so that as we progress, your questions or compliments can actually be addressed along the way. So thank you very much, and I request Sarah to proceed.
Okay. Good afternoon to every one of you. As you've heard, my name is Sarah Gikonyo. I'll be presenting today on the discussion of biochemical assessment in medical nutrition therapy. This is our second series of the webinar. The previous one was on nutrition focused physical exam. And with this, we'll be able to correlate between the two and among all the steps of nutrition care process that we mentioned in the previous series. So the domains that we had highlighted on the previous webinar series was food nutrition related history, anthropometric measurements, biochemical, and biochemical assessment, which we're going to discuss today, and nutrition focused on physical exam, physical findings, which was discussed in the previous webinar series, and client history as well. Okay. So our learning outcomes are: one, to understand the interpretation of biochemical data, and two, to relate biochemical data to nutrition diagnosis and intervention. So today we have a case presentation, and I'd like you to observe the slide that has been presented, and within that we have a poll that I'd like you to participate in, that states, with the anthropometrics displayed in a bit. Yes, with the anthropometric displayed, can you accurately determine the nutrition status of the client? As okay, what is the nutrition status of this child, of this child? Of this child, is it well nourished, undernourished, overnourished, or are you not sure? Just choose one of the above. We have I'm sorry for that delay and confusion a bit. We have a second poll. This time it's different because we have an image. So Do you think there's a difference between the two? With one without the image and one with the image, would you accurately determine the nutrition status of this child? Let's kindly continue with the poll. The second poll. The second poll is running. End the poll. Okay, now, based on the first poll, some of the participants, 6% has voted for the child being well nourished, while 47% of the 47 of the participants voted undernourished, while sorry, we are now projecting the first poll of the results. At 17%, we had participants who say the child was well nourished, and 35% say the child was undernourished. 3% say the child was overnourished, and not sure was 46%, which was the highest. While the second poll, we note that there's a change in decision. One, we see at 6%, participants said that the child was well nourished, while at 47%, which is the highest, it is noted that the child is undernourished, while 37% the child is overnourished, while 10% are not sure. So, okay. Now, okay. Now we'll discuss the case study. In the example above, the child would be noted to be overweight or obese, yet in the aspect of malnutrition, noted, the results would be false. Hence, it would be important or paramount to say that it is good to have client history, just as we learned in the previous webinar series, that client history is very important before you start either assessing the child using biochemical or clinic or having any other intervention, so that you're able to observe the child, what is the diagnosis, and two, you're able to check maybe in terms of, if you're able to see the baby physically, you would note that anthropometric assessment will not be a good measure of assessment in this situation, since the child has bilateral, has an ASACA, which means generalized edema. So it will give you wrong results, meaning even if you are to take MWAC, the child will also be noted to have overnutrition. If you are to take weight and height, you would note that the child is having a Z score of above 1. Yet in the case, it's just that the baby is fluid overloaded. That's why the results are actually false positive. Now, we would like to ask ourselves, what is biochemical assessment? Biochemical assessment is an assessment technique. Sorry.
Yeah, sorry, we are addressing back in the technical hitch, but I think we are set and ready to go.
Okay. Okay. Now in this slide, we are going to discuss what is biochemical assessment. It is a technique of nutrition status, and it entails measurements of nutrient levels or their body metabolites, which means tissues or fluids. And it also discusses the tissues desaturation, meaning SpO2 levels or the level of oxygen in blood. Enzyme activity, like catalytic properties of an enzyme, such as lipase, which is an enzyme which is able to digest fat in the gut, or blood composition. The blood components include plasma, red blood cells, white blood cells, and platelets. Okay. Why is biochemical assessment very important? Okay. It is important because, one, it gives you accurate data as compared to clinical, because in a perspective of maybe from the previous example that we actually shared of that child, one would tell that maybe if you have not practiced for long, you wouldn't know whether this child is actually overweight or underweight, or actually has malnutrition. But if you're able to do the biochemical assessment, you'll be able to tell that this child has a nutrient deficiencies such as albumin, indicating that there's protein deficiency. Okay, another importance of biochemical assessment is that it can detect early signs of deficiency before they are actually seen clinically. In tests such as pre-albumin, they're able to tell that one has a nutrition deficiency before it manifests clinically, such as in a case of edema. So you'll be able to intervene promptly. But it also has a disadvantage since it is time consuming and it's costly. Even though we're sensitizing that biochemical assessment is actually important, it cannot work alone, as we said earlier. You have to use other forms of assessment, the client history. You also have to conduct the nutrition focused physical exam, so that even before you request for this biochemical assessments, you're able to request the correct ones, because already we have said that it's actually costly. So there's no need of you requesting for all types of biochemical assessment yet. In this, based on the client history, it's not important. So we actually request for what is important based on the client history, meaning the medical diagnosis of the patient and the clinical presentation. Okay, now we'll discuss about the confounders. which means factors that affect accuracy of results. One is human error. The way, okay, now that we said that biochemical assessment involves body fluids, right? Which is blood. Most of the time, that's what we use in assessing. So, for instance, if a sample is mislabeled, because sometimes you find that there are several patients in a ward, and one, or maybe they have similar names, it would be important for you to specify using maybe the patient's number, so that you're able to distinguish the samples, because there might be sample mislabeling that can actually give you false results. And that is why it is very, very important, as we said earlier, to do the client history and conduct the nutrition focused physical exam, because you might find that in some instances you have maybe a patient presents with low albumin levels. You'd expect clinically this patient has edema, but when you go to the patient physically, you'd find that maybe that patient is very stable with no edema. So in that aspect, you know that there was maybe human error. So that's why it is important to, other than using the biochemical assessment as a sole assessment method, you're supposed to use the nutrition focused physical exam and the client history. So validity of the results is also a limitation sometimes, because one, for instance, if a sample is collected early, like for instance, blood sugar. Blood sugar, when you are measuring for RBS, random blood sugar or fasting blood sugar, in most of the time in diabetic in patients with diabetes, either diabetes insipidus or diabetes mellitus, we use the glucometer, and glucometers have the strips. If you are to swab the patient and leave the strip in the glucometer for long, it actually oxidizes. Okay, so you're supposed to prepare in advance, other than just maybe you find that you don't have one thing before you measure the patient. You're supposed to have you should prepare yourself in advance. When you're going to a patient, you have your strip, you have your glucometer, you have your swab, and you have everything in order, so that when you're going to take the random blood sugar, you swab the patient first, insert the glucose strip inside the glucometer, and take the random blood sugar immediately, so that the strip does not oxidize, giving you wrong results. Drug effects. Some drugs can actually give you either they give you wrong results. For instance, potassium sparing drugs such as aldactone. They increase serum potassium. So it's not all the time that you actually have hyperkalemia due to the patient being sick. Maybe it's the drug. So it's important also to check what the patient is on. Okay, now then we have baseline biochemical parameters. These are the paramount things that, okay, basically what a patient presents with, these are the things that come into mind at first before anything else. One, if maybe a patient is unconscious, what will you want to check? The blood sugar is very important. Maybe the patient went into hypoglycemia, that's why they're unconscious. Okay, full hemogram. What does full hemogram entail? It has the white blood cells, neutrophils, lymphocytes. It has several components. We also have platelets. We have red blood cells. We have hemoglobin levels, and we have mean corpuscular level. Okay, mean corpuscular volume levels. with this one, in the aspect of maybe the white blood cells, it will be important for you to check on it, because if a patient has an infection and maybe the patient also presents with hyperglycemia, the hyperglycemia in the context of not having diabetes will be related with the infection. So sometimes not all patients who have hyperglycemia have diabetes, but in some cases, because of infection, it can actually raise the sugar, or even in the cases of sepsis, you can either have hyperglycemia or hypoglycemia. So that's why it's important for you to check the full hemogram. Secondly, the HB and MCV. There are various types of anemia. Not all types of anemia are related to iron deficiency anemia. So it's good for you to check which type of anemia is. And this one, you'd be able to tell using the HB and MCV. There's macrocytic anemia, microcytic anemia, and normocytic anemia. Under those three classifications, there are also types of anemias. Like for instance, in microcytic anemia, you find that there's an example of iron deficiency anemia. Okay. And then we have urea, we have UECs, which is urea and electrolytes. These ones are very important to check, because urea, actually UECs involves sodium, potassium, urea, and creatinine. It tells you the functionability of the kidneys, but not all the time. Sometimes you might find someone has elevated maybe sodium alone. It may be as a result maybe of dehydration, but it's not cast on stone. So it's good when you check, you relate the biochemical parameters to the diagnosis and the client history. Okay, we also have liver function tests, which includes albumin, total protein, and bilirubin, and the liver enzymes, such as gamma GT and ALT and AST. Bone chemistry, we have calcium and phosphorus in part of extended UECs. Okay. Now in the earlier we had given you of the same presentation. Now we have the client history. As we mentioned earlier, that client history is very important and nutrition focused physical exam. So let us observe let's observe the case study, so that we figure it out whether we can have different opinions of the previous two polls. So here on this current case study, it's a 2-year-old boy reported with loss of appetite, born to term with 3 kgs, faltering weight, poor feeding for 3 weeks, diarrhea and vomiting for 3 days, and fever of 38 degrees. So this patient is on clindamycin, which is it's an antibiotic, and paracetamol. And in the nutrition focused physical exam, the patient presents with anasaka, which means generalized edema, grade 4 pitting, facial puffiness, hair which is thin and sparse, which is sparse and discolored. Okay, the current weight is 12 kgs with a height of 83 centimeters, with a Z-score of above 1 standard deviation. The MWAC is 13.5. So the diet history, we note that the patient had a pre-admission, the child consumed porridge with some milk, mashed potatoes, pumpkin, and spinach. Currently, because the child is very sick, the child is he's not able to eat orally, so he's on dextroside, alternating with saline. Now, The third. Okay, based on the current, the case study that you just displayed, we have another third poll, which is going to be projected in a few minutes. So we can, I'm sorry for that technical glitch. The poll is about to be projected. Okay, I'm sorry the poll has not been highlighted, but the question is, based on the case study that has been presented, which biochemical parameters will be of key interest to you? Is it one, blood sugar, in the blood sugar, full hemogram, urea, electrolytes, creatinine, liver function tests, bone chemistry, INR, or all the above? You can kindly comment on the chat box. We'll be able to see your comments. We'll give you a second to comment on the chat box based on the case study that has been projected to you. So we have blood sugar, we have full hemogram, we have full hemogram, we have UECs, liver function tests, bone chemistry, INR, and all the above. We're able to see your comments. They are coming in. Okay, we'll end the poll now. Okay, now, in the aspect of blood sugar, in view of poor feeding with the patients on IV fluids and fever, it will be important to monitor blood sugar. So the ones who mentioned blood sugar as being a key interest, that is true. While full hemogram In view of the photo, it may be that the patient may have an allergic reaction in relation to white blood cells. And additionally, anemia may be observed due to deficiency in diet. Since we saw that the patient is usually consumes porridge, which is starch, mashed potatoes, which is also starch, while pumpkin is a starchy vegetable, and spinach, which is also vegetable. So you would observe in the full hemogram would be important because you'll be able to check the HB, the hemoglobin levels, and the mean corpuscular volume to determine which type of anemia this child has. Urea and electrolytes is also important because in a child who, or in a patient who has edema, you'd find that you have dilution on sodium, meaning because the fluid, the extracellular fluid is so much, the serum sodium will be diluted. So it's not necessary that it's a true picture that this patient has hyponatremia per se, but it's because of the edema which is present. LFTs are also important because especially of keynote will be the total protein and albumin. We know that in patients who have edema, especially in babies, they tend to have protein energy malnutrition. And with protein, you will tell with using the biochemical parameters, you will be able to tell that by checking the albumin levels. Bone chemistry is also very important because this is a child, right? And a child, you expect that there are some deficiencies like calcium. Based on the history, even though we have not been able to be told how much dairy this child is on, because we have been told that the child is with some milk. So meaning, is this child able to take adequate milk? And that is the only source of protein that we have seen based on the food history. So you'd find that maybe probably the patient would present with hypocalcemia, meaning low calcium levels. And this in turn will lead to a risk of developing rickets. So that's why it is important to actually conduct the bone chemistry, which involves phosphorus and calcium as well. So that's why it is important to actually note that all the parameters are important to check, but it is based on the clinical history of the patient and the nutrition focused physical exam. Okay, now we have an image showing extended UECs, meaning sodium, potassium, fluorine, urea, creatinine. We also, in this same image, we have LFTs, meaning AST, ALT, and gamma GT, which is YGT. And then we also have total bilirubin and direct bilirubin, which are part of LFTs. The extended UECs that we talked about, the bone chemistry, are calcium and phosphorus. CRP is for indicate, this is C-reactive protein, is to show whether the child has inflammation or not, or whether there is infection. Okay, so based on this image, we see that the sodium levels are in range, so meaning the child has no sodium deficiency. Secondly, we have potassium. Potassium is also normal. Urea is high, is slightly elevated, and creatinine is also elevated. Okay, we go down to LFTs. LFTs are our key concern. We talked about albumin, which is a measure of protein. We see in this image, based on the clinical presentation that we projected earlier, that the child had edema, generalized edema. So that's why we see that the child has what? Hypoalbuminemia, meaning low albumin levels. Okay, in the extended UECs, we see that the phosphorus levels are normal, but the calcium levels are low. Based on the based on the dietary history of this child, we saw that the child is only able to take some milk. The mother was not able to quantify the amount of milk, and in some occasions you can find that the child was not able to take it on a daily basis. So that's why we see that the patient has hypocalcemia, meaning low calcium levels. So this will be a guide for you to actually intervene. When you have all these, you should also be planning about an intervention in the long run. So before we go to a conclusion, what would be our intervention? One, we'd want to encourage this mother to actually improve on their protein sources. Maybe you'd want to do nutrition counseling to this patient. After the management of malnutrition is already conducted, it would be paramount for you to actually do nutrition counseling and sensitize on the importance of protein. Because as we've seen from the diet history, there's a lack of protein intake. Secondly, you'd also want to sensitize on the adequacy of calcium, dietary calcium sources, so that you're able to correct the calcium levels, because it's not entirely so low. So you might find that the medical personnel, the medical team, or rather the doctors, may not have the need of actually correcting it using medication, but they would suggest that you do dietary sources. So it is important for you, after you've done the counseling, you also sensitize on calcium sources. Additionally, it would be also good for you to sensitize on sunbathing, because we know that calcium is actually absorbed when vitamin D levels are available. So sunbathing enables absorption of, when you get vitamin D is produced in the kidneys, but it is activated using UV rays. That's why we actually sensitize children or adults to actually sunbathe. So that's why it is important for you to, apart from sensitizing on the dietary aspects, it's also important for you to do you sensitize on sunbathing as well, so that vitamin D and calcium and phosphorus work together. Okay. And in terms of maybe the C-reactive protein, maybe there was an infection or inflammation, it would also be good for you to sensitize on hand hygiene. Based on this age, it is very important for you to sensitize on hand hygiene as well. So as we conclude, it is good to note that we cannot interpret the values without the other forms of assessment, just as we said, or as we have discussed in the case presentation. It is important for you to include the client history, the nutrition focused physical exam, food and nutrition related history, and the anthropometric assessment. If you are able to get the client history and nutrition focused physical assessment, it would direct you. It would give you a clear direction of whether to actually conduct the anthropometric assessment, meaning weight and height, or MWAC. Okay. So other than you going to the patient first, and then you realize that you already have a weighing scale by the bedside, and you find out that the patient has edema. So would you go back with the weighing scale without measuring the baby? That's why it's actually very important for you to go through the file, determine the client history first, and conduct the nutrition focused physical exam. Then you will be able to have an intervention at hand before you go to the patient. And also, if this results, it will actually give you the best intervention for you to conduct, and which other forms of monitoring tools will you actually have. Are you going to use anthropometric assessment in, let's say, in the case study that was presented? Is it actually safe for you to use anthros in monitoring and evaluating the child? Is weight an important measure? Yes, it is, but it's not an important measure in determining Z-score in this perspective, but rather to determine the loss of fluids when the patient is actually healing, meaning the edema is actually resolving. So you'd want to tell how much edema this child is reducing per day. So that's why weight is important, but not in the aspect of determining Z-score. Thank you.
Well, thank you very much, Madam Sarah, for the knowledge you've shared. And I think the floor is open. You can type in your questions so that we can have them respond. When I look at our Q&A section, there is someone, Boaz, who is asking whether we can prescribe RUTF to this client. Maybe take us to the slide where you had the client history, so that he wants to know, can you give RUTF to this client? Well, I think it would be prudent to get to know from the history. There is the mention of about said diarrhea, and realize that in as much as also we also have an antibiotic on board, then of course the pre-existing diarrhea, then we also have an onboard antibiotic also to treat the pathogen possible. But again, prolonged exposure also has the risk of also exacerbating the diarrhea. So in this case, we also give RUTF. You're actually likely to trigger in now what I would call it's called osmotic diarrhea, by virtue of the fact that RUTF has the concentration count of, let's say, glucose, fat, and the rest, which also may now eventually manifest as either steatorrhea, as in fatty stool, or the sugar therein in RUTF may tend to actually tend to worsen the context at hand. So ideally, RUTF may not apply for this case. Good. Any other question, concern, compliment? Which is the SK is asking, which is the recommended sunbathing, direct or under the shade? Sunbathing, especially in areas with high temperatures like Wajir or Turkana. Well, sunbathing in this case, of course, depending on the location, Wajir, Turkana, as early as maybe 7 o'clock, even towards the 10 o'clock onwards, of course, the temperatures may be super high, and therefore, of course, the under the shade may apply. But in temperate climates, you'll find that, of course, like talk of the western, regions, maybe even Nairobi, the sun gets hotter at past around from 10 o'clock onwards. So it's actually regional based. I would say, depending on context, now the mother or caregiver has now, of course, literally the sun is scorching, then of course that's not sunbathing, but rather now you need to find a sheltered area to that place. Yeah, so sure, blanketly 8 to 10 o'clock are the design, preferable hours of use. But then as it gets hotter, then of course you could do some, under the shade for that matter. But now 8 to 10 precise.
Additionally, it's also important for you to actually expose the child as much as possible, so that, meaning you're supposed to remove as much clothing as possible so that the much of the skin is actually exposed, other than just having clothes and then you're exposing the child. So it's good for you to expose the child with as minimal clothing as possible.
Now, Nalinchandra Karia is asking, nutrition-wise, vegetable diet, is it vegetarian or vegetable? Yeah, I guess should be vegetarian diet is more advantageous, your comment. Well, I doubt whether that comment is attached to the presentation, but then I suppose it is applicable if you're discussing on matters around healthy eating. So for the purpose of discussion, I think we won't actually delve into now the type of diet she has actually put across. Anonymous attendee is asking, how do we differentiate between ascites and marasmus? difference between ascites and marasmus. Well, you'll find that with ascites, mainly for patients who present with, say, liver-related conditions, then ascites usually it actually is localized. Now, but for marasmus, you'll find that we are aiming at a situation whereby either it is generalized, as in the degree of manifestation is not localized as would be in the case of ascites, because actually ascites is organ-based, but marasmus, which is now attached to matters protein energy malnutrition, is more or less generalized. Because with the marasmus, you can have grades of grade 1, 2, or 3 in terms of now assessing edema, but with ascites, local to the abdominal region. The other question is mashed potatoes correct for such age? Mashed potatoes, is it correct for such age? Well, this calls for the need for attendance of MCH clinics, where now the nutritionist has to do timely and objective education in terms of complementary feeding. That's why it is prudent that community outreach and sensitizations come in handy. And also now, just even if you have a friend, relative, or neighbor with a child approaching the right age for complementary feeding, that is now at 6 months onwards, reach out to them and emphasize on the role for education and counseling in terms of complementary feeding. So that in this case, we are doing mashed potatoes, of course, well, in part you would say because the mother was seeing the child is sick, then it was actually helping in mastication. But the challenge is when you look at the combination, potatoes and then pumpkin, which means double starch. Well, in this case, basically, the role of early education in matters of complementary feeding is prudent, so that now the mother can actually have, or caregivers can actually adopt good practices as pertains to feeding these children. So the issue of interest is education. Not the potatoes, but now education, but of course, detail, as I've said earlier, by virtue of sickness presenting, then it will be prudent for the mother to presume that mashing will actually help the child in just swallowing. Although the combination now dilutes the intention, because you find that you expect a single starch and then top it up with maybe some protein and then a vegetable to make it balanced. Now, Norbert Pesci is asking, what are your comments about the high level of urea and creatinine that could be due to renal problem? So what are your comments about the high level of urea and creatinine that could be due to renal problem?
Well, perhaps if I may respond to this. This was a case study, and most likely these lab results were purposely for learning, and it may not really actually reflect the true picture of how we are seeing that child. But as you can see, the importance of biochemistry and biochemical data is that, like, if this was a renal patient, it really means a lot, because I, as a nutritionist taking care of a renal patient, I'll be able to pick the creatinine levels, have estimated glomerular filtration rate, accurate online, and I am able to know the staging or the stage at which the patient is, if this is a CKD patient. And from there, this will give me a lot of information on how to go about in terms of what kind of foods to restrict. Yeah. So maybe that's what I could say. But characteristically, these lab results were picked from a renal patient. Just to say that, yeah.
Okay, thank you, Alexander, for the feedback. Although now when it comes to, of course, clinical management of this case, we find that the clinician coming on board, they could do possibly a kidney challenge to help in delaying this patient, so that in the event the numbers don't improve, then of course, I mean, scaled up interventions like say maybe CAPD, that is you do peritoneal dialysis, or maybe just hemodialysis, help in the short term to correct the figures. But then with time, we expect once the child becomes stable, then of course the numbers can normalize. Although now in the initial phases, of course, you just be a watch and see, meaning given the period the child was diarrheaing or maybe vomiting, and therefore it means they're not feeding adequately, then autonomically the body begins now to start catabolizing in response to sourcing for energy to see this child survive. So that's why initial phases of care possibly could be just like, let's watch and see, before now you scale up to maybe more advanced interventions, like maybe dialysis. And Geoffrey Moyale is saying good presentation. Now, matters CPD, you'll be responded to. And then we have Mustafa asking, can diuretic drugs have impact on albumin levels? Diuretic drugs, can they have impact on albumin levels? Well, I would say yes. Yes, in the context that if you diurese more, it means actually you end up doing hemosaturation. So the serum levels you actually tend to show as though the levels are raised. Just the same way, if the patient is actually now has edema with fluid retention, there will be hemodilution. So in this case, at times it will also be easier for you to presume as though the levels are low. But now, because of the super dilution of retained fluids in the serum, of course, the levels may tend to be low. But now, when you bring in diuretics, it actually tend to do what? To show that the levels have risen, but actually the risk is you may end up now going into a negative fluid balance. Yes, unless there is another input. Yeah, good. Thank you. So somebody is asking, just a comment. Can BMI be used as a measure to tell malnutrition in a child? Samson Buru, can we use BMI to measure malnutrition in a child?
Well, what I would say is that we have a pediatric protocol, and if actually we are managing for malnutrition, what we normally use is Z-score, weight for height, the one that has been recommended, and we have the cutoff points, and also we have MWAC, normally used for screening, but MWAC at indicated cutoff points can indicate whether patient child is well nourished, moderately undernourished, or severely undernourished. And also, like in case of bipedal pitting edema, that is on high grade, like grade 3 alone, it's enough criteria to consider such a child to be severely malnourished. But for now, I've not come across whereby BMI, we in the national guideline, we can use BMI alone, for treatment of malnutrition.
Well, if I may add to that, is in terms of BMI has also its own downside of it. And then now the BMI, there's the BMI for age, which usually is done for children above 5 years. So you cannot do a BMI for a child who is below 5 years to be able to tell the issues to do with malnutrition. And as we had discussed even in the previous webinar, you see, key thing is it's not just about the anthropometry, it's about what's the picture behind the anthropometry that you're having of the patient, so that can be able to diagnose the patient accurately and effectively. So it is very important for you to have the clinical picture rather than just having data in terms of anthropometry, because that might mislead you. Because for example, for the case that we are having, you see the weight is normal for that age. So do you still go ahead and say this child is well nourished? Had you not had the picture in terms of the patient is having an asaka? So probably even the weight itself is exaggerated simply because of fluid retention. So you can see, and whenever you're having fluid retention, definitely it's going to impact on your value in terms of the BMI that you're going to get at the end of the day. So you should be able to just be using one parameter, one parameter to determine the malnutrition status of a child. Thank you.
Thank you, Agri, for the input. Now, Hilary Aworia is asking, how was the visual acuity of the child, and by extension, hearing level in consideration of micronutrient loss or deficiencies? How was the visual acuity of the child, and by extension, hearing level in consideration of micronutrient loss or deficiencies? Well, of course, the child was conversing, and that's possibly it was an oversight in the discussion being put across. Otherwise, as part of the client history, the mother having reported now maybe a loss of hearing or maybe matters around vision or the sight, then of course it will be a prudent issue that actually will involve in deciding who also comes on board. Because if actually you are right, if matters around the visual loss, then of course you'd actually think about who we bring on board in terms of care, the role of the ophthalmologist would have come in, or eye specialist. And then if also matters hearing would be an issue, then of course also it actually determines the direction to go in terms of we need an ENT specialist for that much. So actually in this case, yes, the child was seen, and then also would actually hear or whatever, would actually correspond to the caregiver or even the healthcare workers there. And then there is Mercy Chokera. Mercy is talking about matters CPD, so that one will be handled in-house. Rosemary Onyango is asking, while giving the IV fluids to this child, which way do you use to calculate the volume needed? Yeah, good question. So while giving IV fluids to this child, which weight do you use to calculate the volume needed? Well, you use ideal weight. Ideal. Actually, if you do actual, you end up now overhydrating the same child. So you use ideal. So if, say, the child was, say, wasted, then it means now you actually have a negative balance. So you actually, so what you actually do, if say the child was wasted, you do, the goal would be actual weight, but now you step up based on how the child can tolerate until you reach the desired target volume for the desired weight. So in this case, you use actual weight so that now you can achieve, to determine how much volume of the fluid to give. Then there is Mustafa. If you are managing malnutrition for this child, what criteria are we going to use when administering feeds like F75, F7, F100, RETF? So I think we said earlier on that in as much as you are to intervene this child, remember, of course, in relation to the question I've just responded to, we'll actually have what is the required fluid allowance for this child, and we'll find that in managing, say, a severe acute malnutrition, for example, there are protocols that dictate what volume to start with if the child presents with edema or without edema. So, of course, appropriate protocols come on board as pertains to the management of SAM or MAM. So in this case, for instance, you do 100 mils per kg body weight of F75, if that's the starting, and assuming if you want to do NG feeds. But remember, in the initial phase, given that there was the issue around vomiting and also diarrhea, so nasogastric tube feeds will come in if we've arrested the losses. I mean, if the mesis has been addressed or if the diarrhea has in some way resolved. But of course, before even heading there, is the use of, let's say, or ORS to help in addressing the diarrhea, on top of also zinc sulfate for that matter, plus any other pharmacological agents that will be of need. Yeah, thank you. So I suppose, unless there is another question, we can call it a day, and we look forward for you joining our subsequent webinars that just a moment. So there is a display there around public, to inform those of you who've been having questions around CPD. So I think just go through. Yeah, so I suppose the communication is clear to those of you who had questions around CPD award. Yeah, so I think we can call it a day.
Thank you very much for that wonderful presentation. Remember, this is our series. We started with the nutrition care process. We covered on focused nutrition focused physical examination. Now we have done a bigger, we have done into details on how to go around on anthropometrics, interpretation, and biochemical assessment. Remember, you cannot just pick weight and height and do a proper management to the patient. You really need to have all 5 components of nutrition assessment so that you can be able to derive a very accurate nutrition diagnosis that which for nutritionists listening, that you can be able to come up with a nutrition label or diagnosis that you independently you can be able to have influence either to resolve or mitigate in order to improve the patient treatment outcome. So that's all for now. We'll be sorry. Okay. Oh, these are more comments. I don't think we have more additional questions here. And that is, yeah, Madam Wareva, we have seen your comment. Thank you very much. We appreciate your mentorship. So until then, we'll be able to put a notice on what is next in our series. And we'll be continuing with this series until we have done the complete package on nutrition care process. Thank you very much.
Okay, bye guys. So see you next time. Have a blessed Eid. Thank you.